Hello, and welcome to today's webinar, Using SBIRT When Intimate Partner Violence Has Been Disclosed. We are pleased to have with us today Michelle Beaulieu with the University of Maryland, Baltimore School of Social Work. I'm Tracy McPherson, and I'm going to be your webinar moderator today. I'm a senior research scientist in the Public Health Department at NORC at the University of Chicago. I also am the lead training, technical assistance, and evaluation point of contact for all of NORC's SBIRT projects. I'm also the project lead for the NORC's collaboration with the National SBIRT ATTC, and I would just like to encourage you to reach out to me if you have any questions about anything with today's webinar, any of the webinars in our series, or any of the work that we're doing. I would encourage you to reach out. I'm glad to help you think through what you're doing in your own sites, provide technical assistance, and I just want to say thank you everyone for joining us today. It's really nice to be able to produce this webinar in partnership with the National SBIRT ATTC and with the Brief Intervention Group and NORC. All of our collaborative work and a lot of resources and materials related to SBIRT education, including IPV and webinars specific to other topics, particular to alcohol, tobacco, marijuana use, and other areas where SBIRT has been applied. You can find a lot of that information on our website at sbirteducation.com. Today's webinar is one of the webinars in our 2017 series that you can see we have just launched. We have several webinars this year that are actually focusing on this very important topic of intimate partner violence, or IPV. This month, today's webinar, as well as next month on March 2nd, we will have two webinars that are really focused on this particular topic, creating a bit of a mini-series around this very important area of interest. I would also encourage you to take a look at our on-demand webinars. We have done other webinars in the past on this topic, and this complements rather than duplicates what we've done in the past, so I hope you'll take advantage of that on-demand learning. And also, I hope you'll visit our hospitalsbirt.webs.com website, where you can see the full listing. You can register for all of the webinars in the series on that website. You can download a flyer and share that with your colleagues. All of them are free, open to everyone, and we really encourage you to take advantage of the education. So thank you for joining us today, and we look forward to having you on future webinars. All of the materials for today's webinar can be accessed on our hospitalsbirt.webs.com website. If you click on the Webinars tab, you'll actually see this webinar listed. You can hyperlink to this webinar, which will have its own page. There you'll find a copy of the PowerPoint slides. They're already there. In addition to that, they're made available to you in your GoToWebinar pane over to the right where it says Handouts. You can actually download a copy from there as well. In addition, you'll find materials and resources on SBIRT, on IPV, and many other resources on SBIRT there. And you'll also be able to access the recording. So we'll make this available on demand, and it will be available 24/7. And we hope that you'll take advantage of that, share it with your colleagues, and you'll come back to visit us and look for additional resources there. If there's anything that comes up during the webinar today, there's information that our presenter decides she would like to share with you after the webinar. We generally post those materials there as well, as opposed to sending those out by email. So you can check back there if you're looking for something particular. In addition to that, we will offer a certificate of completion, and our certificate of completion, there'll be a link on this web page where you can complete a brief online form to claim your certificate, and is also where you can get the CE credit, and we're offering 1.5 NADAC CEs with the certificate. After our webinar today, at the end of our presentation, we're going to open it up for questions. Now, typically up in the right-hand corner of your monitor, you will see the pane, the questions pane. This is where you will type in any questions that you have. What I would encourage you to do is when you have a question, it could be at the very beginning, it could be the middle, the end, just go ahead and get it into the queue. In case we get towards the end and there are lots and lots of questions, we want to try to get to your questions, you know, as many of them as we can. And so I'd say while you're thinking of them, go ahead and enter those in. They'll save, and we will we'll present those to our presenter at the end. Behind the scenes is our technical facilitator, Misty Story. If you have any technical questions about GoToWebinar, the slides, or other things, she'll be responding to you through the GoToWebinar pane, and she'll be able to help you with some of those technical questions. And so now it's my pleasure to introduce our presenter, Michelle Beaulieu, who is with the University of Maryland School of Social Work. And Michelle is a licensed clinical social worker and has spent her professional career working in the fields of intimate partner violence, or IPV, and women's health. She currently works for the University of Maryland School of Social Work, overseeing 2 federal grants, working to increase the competency of graduate social work students in behavioral health and SBIRT. Prior to this position, she worked at the Maryland Department of Health and Mental Hygiene as the coordinator for Project Connect. Project Connect is a project to build collaborations between the public health and domestic violence fields, training reproductive health professionals how to screen and provide brief intervention for intimate partner violence and reproductive coercion to their patients. Michelle also worked for 7 years as the clinic social worker for the Women's Health Clinic at Johns Hopkins Bayview Medical Center. Previous to this, she worked for 17 years as a domestic violence advocate and counselor. So it's my pleasure, Michelle, to have you today. So I'm going to turn it over to you.
Great. Thank you, Tracy, and hi, everyone. Thank you all for joining. I want to preface this by saying that I come to this topic primarily as a practitioner in my former life and as a trainer. Over the years, I've listened to the stories of many women and have thought about those experiences and continue to try and understand how we can best support women experiencing intimate partner violence. I'm also going to preface my remarks by stating that I'm presenting using the lens of gender-based violence, defining the victim of intimate partner violence as female. The majority of those persons experience IPV. I don't mean to exclude the experience of others, lesbian, transgendered, gay, or male survivors. If we know little about women who experience IPV and use substances, we know even less about the experience of these other individuals, and we certainly need to know more. Hopefully this webinar will give you ideas to ponder and conversations to engage in. Unfortunately, these issues are not going away very easily. Okay, I have a few questions that will help me better understand who's on the webinar and help me potentially make some adjustments of emphasis. So the first question, the first poll is, from what lens are you viewing this topic? As an IPV service provider, a substance use treatment provider, a healthcare provider, mental health provider, an academician? Unfortunately, this may not fit everyone's experience or lens, but if you're able to select one that is your emphasis, please do. We're going to take a few seconds to let you respond, and then we'll reconvene. Okay, thank you. So I see that a lot of you are direct service providers, many more in the areas not as IPV providers. So that's good for me to know. Thank you. So let's move on then to our next polling question. Have you had any SBIRT training before? Please select one, yes or no. Again, we'll take a few seconds to let you respond, and then we'll reconvene. Okay, wonderful. So a majority of you have had SBIRT training before, because I'm not going to spend a great amount of time looking at the SBIRT intervention overall, but more looking at it in terms of how we might modify it for women who have disclosed intimate partner violence. Thank you. And now the last polling question, have you had training on intimate partner violence? Please select one, yes or no. We'll take a few minutes, a few seconds, and then we'll reconvene. Okay, so we're about split on that. So I think there'll be some, some portions of what I present today will not be new to each of you. We have a varied audience with different experience and knowledge bases around these issues, but I'm hopeful that you will come away with some new thoughts, ideas, and information. Thank you for answering those questions. So in terms of what I hope we will accomplish today, first, definitions, so it's clear what we mean when we're using these terms. Then some information on prevalence and the known impact of intimate partner violence and at-risk substance use. What we know and what we don't know about the co-occurrence of intimate partner violence and substance use. And then exploring when and how we might consider the use of SBIRT with victims and survivors of intimate partner violence. Are there contraindications? Do we need to consider tweaks or modifications to the intervention? And then, coming to the end, what do we need to further understand and evaluate regarding these issues and their co-occurrence? And of course, time for questions at the end. It's clear that depending on the particular study, organization, or vantage point, terms and definitions differ regarding intimate partner violence. We hear family violence, domestic violence, intimate partner violence. They mean similar and different things. Additionally, many research studies and criminal justice data sets investigated and measured physical violence as IPV. But as we've listened, we understood more fully the lived experience of victims, which usually included sexual violence, psychological abuse, coercive control, and other tactics of abuse. That's why I like to use the CDC definition, and this is also the CDC's attempt in their uniform definitions and recommended data elements to get all of us working from similar definitions, so that we all mean the same thing when we say intimate partner violence. So it includes physical violence, sexual violence, stalking, and psychological aggression, including coercive tactics by a current or former intimate partner, which can be a spouse, boyfriend, girlfriend, dating partner, or ongoing sexual partner. An intimate partner is a person with whom one has a close personal relationship that may be characterized by the partner's emotional connectedness, regular contact, ongoing physical contact and sexual behavior, identity as a couple, and familiarity and knowledge about each other's lives. The relationship need not involve all of these dimensions. It's a broad definition of both the tactics of abuse and how we define an intimate partner relationship. The CDC's National Intimate Partner and Sexual Violence Survey, which is probably the preeminent national survey that has given us the best look at incidence and prevalence of IPV, found that 1 out of every 3 women in the United States report the experience of intimate partner violence sometime during her life. This percentage has been replicated in other studies, and it is astounding. Additionally, if you look at some of the other demographic breakdowns, younger age groups, women 18 to 24, and women of color have even higher annual and lifetime incidence rates, according to this national survey. What do we know about the impact of intimate partner violence on individual women who experience it? There are many potential impacts to physical and behavioral health, as well as social consequences. In terms of medical symptoms and conditions associated with intimate partner violence among women, there are, of course, physical injuries, bruises, lacerations, fractures, burns, dental injuries, strangulation, and death. Mental health sequelae such as depression, anxiety, post-traumatic stress disorder, eating disorders, phobias, panic attacks, insomnia, and suicide. Substance use, tobacco, alcohol, prescription and illicit drug use. Chronic disorders, everything from chronic pain, anemia, asthma, obesity, diabetes, hearing loss, TMJ disorders, fibromyalgia, and GI disorders, cardiovascular disorders. Many of these associations have come from what we are learning about the effects of chronic stress on health. And then, of course, reproductive health, pelvic pain, sexually transmitted infections, including HIV, unintended pregnancies, poor prenatal behaviors, and poor pregnancy outcomes. I just want to give an anecdotal example in terms of like poor prenatal behaviors. Having worked in a women's clinic, I had the experience with a woman who was not coming for her prenatal visits. And, you know, of course, we often are quick to, especially in the medical profession, label women who don't follow what we want them to do as non-compliant. But as I explored this with this woman further and listened to what she had to say, what was happening is that she was in an abusive relationship, and her partner had an expectation, or in his mind a knowledge of what was a reasonable amount of time for her to be at a prenatal visit at the doctor's office. And we were in a very busy clinic. We were a teaching clinic, so we had residents, and you know, physicians were frequently behind, and waiting times could be long. And so what was happening is that when she asked and found out that her visit was going to be delayed, she would leave, because she knew that if she didn't leave and stayed and was over that prescribed amount of time by her partner, that there would be consequences when she arrived home. So I think we have to, again, really listen to the voices of women, of victims of IPV, to understand their unique consequences and impacts of their victimization. So now let's look at at-risk substance use. In terms of working definitions, I'll start with alcohol. According to the National Institute on Alcohol Abuse and Alcoholism, at-risk use for women is defined as greater than 3 drinks a day and greater than 7 drinks total per week. How do we define at-risk use of other substances? All illicit drug use, use of prescription drugs other than prescribed constitute risk. If negative consequences have yet to be experienced, the use is termed hazardous. If negative consequences are occurring, the use is termed harmful. This is where the use of validated screening tools can assist us in differentiating the risk with these substances. But this is not, you know, an easy determination. What about prevalence? From data collected through the annual National Survey on Drug Use and Health, we know that close to 63% of females in the United States use alcohol during the year. According to the 2015 survey, 20% of women report binge use, which is defined in the survey as 4 or more alcoholic drinks for females on the same occasion, meaning at the same time or within a couple of hours of each other, on at least one day in the past month. A little over 4% of females report heavy use, defined as binge drinking on 5 or more days in the past month. Look at the age groups of the 18 to 25-year-old women and see the increases across the categories of use, binge, and heavy alcohol use. This is also the age category of women who report higher incidence of IPV. This graph from the 2008 and 9 national survey data looks at substance use among pregnant women. There is some evidence that pregnancy is a time when women may have increased motivation to stop using substances. Here we see that 15% of all pregnant women report using illicit substances, and almost 17% using alcohol, a little under 15% binge use of alcohol, and over 20% smoking. Also note the higher percentages of use in younger women. Add to this, I selected this slide to have you consider that there's also data that suggests that intimate partner violence risk increases during pregnancy. So what is, again, these are all these thoughts and considerations for us. What do we know about the health impact of at-risk substance use? Physical and mental health associations may vary depending on the particular substance, but overall this looks very familiar to the health consequences of intimate partner violence, with injuries, mental health consequences, depression, anxiety, again, post-traumatic stress disorder, eating disorders, violence, chronic disorders, and reproductive health. Let's look at this side by side, and what does it tell us? For one thing, when we see individuals with any of these symptoms or behaviors, we need to keep intimate partner violence and at-risk or dependent substance use as a part of our differential diagnosis. There might not be intimate partner violence or substance use present, but the individual could be experiencing intimate partner violence, she could be using substances, and both could be present. Both intimate partner violence and at-risk substance use have widespread consequences which necessitate screening and intervention. What do we know about women experiencing intimate partner violence and their use of substances? In a national report on substance use and intimate partner violence, Bennett and Bland summarized current knowledge and reported that between 25 and 50% of women receiving victim services for intimate partner violence have substance abuse problems. Furthermore, women were more likely than men to report that they initiated substance use to alleviate the trauma associated with abuse. In a study from North Carolina, which was reported in the American Journal of Public Health, victims of violence were significantly more likely to smoke, drink, and to use drugs than non-victims. If you look at the links between intimate partner violence, post-traumatic stress disorder, and substance abuse, you also find co-occurrence. Studies have shown that PTSD is common among women experiencing IPV, and that individuals with PTSD are at high risk for substance use. In one study presented in the Journal of Dual Diagnosis, Sullivan and authors found that 15% of women experiencing IPV met PTSD criteria, and those women were 15 times more likely to have days of polysubstance use. In addition to using substances to alleviate the physical and emotional pain of intimate partner violence, there are other dynamics that women report related to their substance use and their partner's behavior. Women report partners threatening to hurt them if she uses, or threatening to hurt them if she doesn't use substances. It could be either or both. Women report partners putting her down and making her feel guilty for past or current substance use, physically abusing her for using substances or for not using substances, for refusing to use substances, keeping her away from people supportive of her recovery, and or preventing her from attending meetings or treatment. For example, sabotaging or refusing to provide transportation to meetings or to a clinic where she receives medication-assisted treatment. If she has ended the relationship, perhaps still stalking her because he knows where her meetings, what meetings she goes to, or her treatment sites. Also saying that she caused the abuse that he dishes out because of her substance use. He's helping her get stronger or better or punishing her. Forcing her to prostitute for drugs or drug money, forcing her to sell drugs, introducing her to substances, buying substances for her, encouraging or forcing her use of substances. This is not an exhaustive list, and this has been termed substance use coercion. The National Center on Domestic Violence, Trauma, and Mental Health, in collaboration with the National Domestic Violence Hotline, instituted a voluntary survey to hotline callers during a 2-week period of time in 2012. Of over 9,300 female callers who identified as a victim or survivor of domestic violence, over 3,200 women who were not in crisis were asked to participate in the survey after its content was described and its voluntary nature were assured. 3,056 women agreed. This is what they first introduced to women. Many times people who call our hotline are dealing with a partner who is trying to maintain power and control in the relationship. Sometimes they may use substance abuse as a way to maintain that power and control. In order to understand how this affects our callers, we're doing a voluntary survey that, just like the rest of the information in this call, is anonymous and confidential. And do you mind if I ask you a few questions? I also think that this is a way of us training the topic when we talk later about SBIRT with victims of IPV. It's a way of introducing the topic using that first part of the way they introduced it to the callers to the national hotline. Here are the questions and the results. 27% of respondents stated that their partners had pressured or forced them to use alcohol or other drugs or made them use more than they wanted. 37.5% of callers reported that their partner had threatened to report their drug use to an authority to keep her from getting something she wanted, like a job, child custody, a protective order. 24.4% reported ever being afraid to call the police for help because their partner said they wouldn't be believed or would be arrested for being under the influence. 26% reported using alcohol or drugs as a way to reduce the pain of their partner's abuse. 15% reported ever trying to get help for alcohol or drug use, and 60% reported that their partner ever tried to prevent or discourage her from getting help. It gives us quite a picture. And then, if you analyze the relationship between some of their responses, 2/3 of women who stated that their partners had pressured them to use alcohol and or drugs also stated that their partners threatened to report their use to authorities, such as Child Protective Services or the police. Almost 70% of women who reported being afraid to call for help because their partner had told them they wouldn't be believed or they'd be arrested also reported that they used alcohol and or drugs to reduce the pain of abuse. Their isolation was compounded. And finally, 94% of women whose partners threatened to report them also stated that their partners prevented or discouraged them from getting help. This tells us a lot, but certainly that if we're going to talk to women about their substance use who have experienced or are experiencing intimate partner violence, then we better ask and listen to better understand the dynamic of their use in the context of the relationship. If we don't, we're missing important information to better understand her experience and information that may inform safety planning and harm reduction. What about the risk of experiencing intimate partner violence if you're a woman with at-risk substance use? Research from women in substance use treatment and other survey data shows an increased risk of IPV for substance-using women. Substance use may impair judgment in terms of risk posed by an intimate partner. It may increase her financial dependence in terms of needing money for substances or in terms of, having a place to live and food to eat, and make it difficult for her to leave an abusive relationship. Use of substances may expose her to men who also use substances and who are also abusive. And it may increase her own aggression and use of violence, which may increase her risk of retaliatory violence by a partner. In sum, substance use by women can be both a precursor and a consequence of intimate partner violence victimization. And we really need to understand more about both directions and women's experience to also help us inform how to best intervene. The shame and stigma of intimate partner violence and substance use is strong and similar and goes further to create barriers to seeking help, from the fear of what will happen if they disclose, to feeling responsible, to feeling less than and worthless. Again, this list is not exhaustive, but you can see for a woman who may be struggling with both issues, who is dealing with both issues in her life, how the shame and stigma may be magnified. We need to be aware of this and understand the reluctance and real fear in disclosing, along with the courage it takes for those who do disclose. Safety includes knowing you are not going to be labeled or judged, and that's the environment that we need to create. While the focus of this webinar is not to look at the relationship between IPV perpetration and substance abuse, I think it's important to recognize the impact on a victim's safety and safety planning. According to the Bureau of Justice Statistics, 2/3 of victims suffering violence by a current or former spouse or partner report that the perpetrator had been drinking, compared to less than 1/3 of stranger victimizations. Among spouse victims, 3 out of 4 incidents reportedly involved an offender who had been drinking. Perpetrators of intimate partner violence are 3 to 10 times more likely to be violent on a substance-using day than on a non-using day. That is something key also to safety planning. Partner substance abuse may increase risk for IPV-related injuries. And again, this is a data set that is only looking at the relationship to physical violence. We know less regarding the relationship to sexual and psychological violence. Certainly this information, this growing research on this association has informed promising integrated interventions in abuser intervention programs. We know that IPV perpetration and substance use must be addressed together. Why universal screening for both intimate partner violence and substance use? Hopefully the case has been made looking at the prevalence of IPV and substance use. Screening also provides opportunities for education and empowerment, education on the impacts, co-occurrence, and harm reduction strategies and services available for victims and who are also using substances. It's also an opportunity for advocacy to support a woman receiving the services she wants, and really to understand the individual's full lived experience and the impact on the presenting problem, how and why she comes to you today. What are the barriers to screening? Certainly discomfort discussing one or both of these topics, especially if we haven't had training. Fear of losing or alienating or shutting down clients. She's not here for this. What will she think if I ask? Lack of knowledge about valid and appropriate screening questions. For many years working in the health, in a health clinic, and even before that working in domestic violence programs, and seeing that the main questions often asked around IPV was, do you feel safe at home? That we have come to understand that as a bad screening question that can be interpreted in so many different ways, and yet you still find it embedded in some electronic medical records. Certainly uncertainty about referral resources, like what am I going to do if she says yes to any of this? I'm not sure what the resources are or how I will respond. And Depending on your setting, it can be time issues, overburdened staff, lack of private space to speak with patients or clients, lack of adequate training of staff, lack of reimbursement, and even our own personal experiences that can be barriers to screening. In the next few slides, I will quickly review screening and a brief intervention for intimate partner violence. Then I'll look at how SBIRT for substance use could be paired with this. So how is it important to start? Certainly privately. We are going to reduce the possibility of a woman disclosing IPV if her partner, a friend, family member, or child is there with her. Addressing confidentiality and what limits we may have to confidentiality, knowing what the reporting requirements are in our state and making sure we inform. And then framing the topic, using some type of script to normalize why you're bringing this up. I don't know if this is or ever has been a problem for you, but many of the people I see are dealing with abusive relationships. Some are too afraid or uncomfortable to bring it up themselves, so I've started asking about it routinely. Use then direct questions and/or a relationship safety card. During last month's webinar, Dr. Heather McCauley presented on the use of a relationship safety card as both universal screening and education regarding abuse and coercion in relationships and the impact on health. I encourage you, if you haven't already listened to the webinar, to do that and learn more about this intervention. It has been evaluated in several different settings and shows evidence of effectiveness at reducing incidents of reproductive coercion and abusive relationships. More information on this intervention and the variety of relationship safety cards that are available and free of charge can be found on Futures Without Violence website. There are many validated screening tools for intimate partner violence. In a systematic evidence review, the United States Preventive Services Task Force noted several screening instruments with high sensitivity and specificity for identifying IPV in the healthcare setting. The Centers for Disease Control also has published a compilation of assessment tools for IPV, and you can get to both of these by just Googling. Here are 3 screening questions developed by a task force of healthcare professionals in Maryland in collaboration with the Department of Health and Mental Hygiene, which directly ask about physical, emotional, and sexual violence. Has your current or former partner threatened you or made you feel afraid? Has your partner ever hit, strangled, choked, or physically hurt you? And has anyone made you have sex when you didn't want to? If you are not an intimate partner violence service provider, what is a brief intervention you can use to respond to the disclosure of IPV? First, validating the client's experience. I'm so sorry this is happening in your life. You don't deserve this. Offer a safety card for the client to review and keep if it's safe to do so. Most domestic violence programs have some sort of safety card with phone numbers, basic safety planning information. If you are not an IPV service provider, it's important to connect with your local program and get these things from them. Ask the client if she has immediate safety concerns and discuss her options. It may mean offering to let her use your phone to call a domestic violence program for further information and support. Many times victims report that their partner is monitoring their cell phone and their text log. And referring to a domestic violence advocate for safety planning and additional support. If you're not an IPV provider, it doesn't mean that you have to be an expert in safety planning, but some basic information and clinical judgment goes a long way, and certainly knowing who your IPV providers are in your jurisdiction. I think the other important thing is that you can provide an opportunity for follow-up in terms of how is she doing, has she made any particular actions towards safety or receiving other services. Safety is a priority. With a disclosure of intimate partner violence, someone should assess safety. This is a 5-item version of the danger assessment developed by Jackie Campbell. Answering affirmatively to one of the 5 questions tells her that she has one of the 5 highly predictive risk factors for serious assault or homicide, and you would highly recommend further advocacy to provide information on options and safety plannings. Of course, there is the full danger assessment used by IPV service providers and first responders to help link victims with high danger risk to safety options. So here are some considerations. Is SBIRT appropriate if IPV has been disclosed? First, consider the level of danger. If a woman states she's in danger and is afraid, screening for substances might be considered only in the context of safety planning. Are you working in an environment that already universally screens for substance use and you have the individual screening results? This might change how the intervention is rolled out. Do you need to understand more regarding the woman's use of substances related to intimate partner violence? This can be part of the brief intervention. Consider if this is the initial disclosure of intimate partner violence. Again, focus is on safety and danger assessment. Or if you've been working with this individual related to a current or former intimate partner violence experience and you haven't already screened for substance use, then SBIRT may be especially appropriate. And finally, clinical judgment. All of these factors create unique situations for every victim. Intimate partner violence disclosure, safety and danger assessment, previous knowledge of intimate partner violence or substance use combine to determine the appropriate timing of an SBIRT intervention. Here is a visual way of thinking about when and where to use SBIRT. If there has not been prior universal screening for substance use, start with the screening, as the arrow suggests. If there has been prior screening, then you can start at the brief intervention. Think of SBIRT as a function of safety planning and harm reduction for IPV. So if you look on the left at the screening brief intervention referral to resources for IPV, you can see that perhaps, or I would have you consider, the best place to embed SBIRT would be under the brief intervention regarding safety planning and harm reduction. I believe that these two interventions or responses closely align in their fundamental values. This adds to the appropriateness of SBIRT as an adjunct intervention in working with women who have or are experiencing intimate partner violence. Both are client-centered, non-judgmental. They respect the client's autonomy and decision-making capacity, and they come from a place of empathy and compassion. Looking more specifically at SBIRT with victims of intimate partner violence, what's important? Certainly, again, privacy. You are, again, more likely to get honest information if the woman is speaking with you alone. Introducing the topic of substance use. Why are you asking these questions? Conveying the message that intimate partner violence and substance use can happen to anyone. Any woman is vulnerable. You are not alone. Letting her know that you're asking these questions to better determine her safety needs. Again, confidentiality, the importance of what the limits of those are in your particular setting, and transparency. Will this impact her ability to receive services? If you are an IPV provider, SBIRT should only be used after a victim has been accepted into your program. It should not be used as a tool to screen victims out of services. The idea here is expanding our capacity to respond to victims of intimate partner violence who may be using substances in an at-risk manner. This intervention may help them to continue to use the services that you provide. SBIRT is also an opportunity for universal education regarding substance use and individual safety. Women may not have ever had the opportunity to speak with anyone about both of these experiences and how they may play out in her relationship. I'm going to briefly go through the pre-screening questions following the SBIRT model. Start with validated pre-screens to determine the level of risk. This is going to determine, again, whether we're looking at an intervention for reducing at-risk use or whether we're looking at a referral to treatment. For alcohol, this can be the audit C. How often did you have a drink containing alcohol ever, even beer or wine in the past year? How many drinks containing alcohol do you have on a typical day when you do drink? How often did you have 4 or more drinks on one occasion in the past year? There is also the single question pre-screen of how many times in the past year have you had 4 or more drinks in a day. A response of greater than 1 is considered positive. Pre-screens for prescription medication. Have you ever taken any prescription medication that wasn't prescribed for you? Have you ever taken any prescription medication in ways not prescribed, used more or less than was prescribed for you? And have you ever taken any prescription medication only for the feeling or experience they caused? Pre-screening questions for marijuana and illicit drugs. Have you ever used drugs such as marijuana, heroin, cocaine, LSD, PCP, methamphetamine, etc.? And if yes, which drugs have you used in the past 3 months? How much are you using per day? When did you last use? And have you ever used drugs by injection? And presenting questions for tobacco. I want to note that tobacco use does not necessarily fit into the domain of substance use coercion that I previously spoke about. I don't think it ties to safety planning in the same way that other substance use potentially does. However, I strongly encourage providers to screen for tobacco use and consider SBIRT at a point in time where safety planning is not the priority. There is data to show that women in abusive relationships are more likely to smoke. Certainly the associations between anxiety and smoking work here. There is also data that suggests that women who are in physically violent relationships during pregnancy smoke at a higher rate during pregnancy than women who do not report abuse. Educating women as to the associations between intimate partner violence, stress, smoking, and health consequences may be helpful in increasing motivation to change. A negative pre-screen for substance use provides the opportunity for universal education. You may just be planting seeds. If it is appropriate, you can validate her intimate partner violence experience. I'm sorry that you experienced or are experiencing abuse in your relationship. You didn't deserve to be treated that way. I'm glad you're safe and know your options, and if you want, we can talk more about it and how the abuse has impacted you, as well as support that is available. And remember that disclosure may not be viewed, disclosure in terms of substance use I'm talking about here, may not be viewed as a viable option. Keep the door open and the opportunity for continued conversation. Disclosure, again, may not be viewed as a viable option for many of the reasons that we have spoken about in terms of the dynamics of substance use coercion. Following the SBIRT protocol, a positive pre-screen is followed by a validated full screen for that particular substance. This will allow you to determine the individual's level of risk associated with substance use and whether a referral for further assessment or treatment is most appropriate. Validated screening tools are available for different settings and populations. If this isn't something you're familiar with, there are many resources. This organization being one of the main ones, SAMHSA and other online training programs that will offer you information on appropriate validated full screening tools. What might be the same, different, or tweaked in the brief intervention for substance use with a woman who has disclosed intimate partner violence? As always, ask permission to share the results of screening questions. Share the results and ask her what that means to her. What's her reaction? Provide information. What do you mean by this level of risk? What are the associated health impacts? And provide information on the relationship of intimate partner violence and substance use including dynamics that women have reported experiencing when both are present. This is the opportunity to further explore possible substance use coercion with the victim. Ask about the dynamics we discussed earlier using questions like the National Hotline Survey, or things like, women often tell me their partners complain about their use. How does your partner show disapproval? Or many women tell me their partners don't want to drink, drug, smoke alone. How often do you find yourself using when you really don't want to? This conversation will help inform safety planning and harm reduction. Then explore the positive. Based on this conversation, she will be able to explore the positives and negatives of her substance use. And then your role, as in the SBIRT intervention, is to continue to reflect and summarize. I maintain that understanding the relationship between the victim's experience of intimate partner violence and substance use, and then using that understanding to work on safety planning and harm reduction, are the most important priorities of SBIRT with victims of intimate partner violence. Safety planning may allow an individual to move on to addressing substance use issues. Harm reduction may further allow a woman to access more intimate partner violence services. Remember the uniqueness of every individual and her situation. Because of what we know about the association of perpetration and substance use, we should also ask about her partner's substance use and make it a part of safety planning as well. Some specific harm reduction strategies. What strategies does she currently use that work around her substance use and the experience of intimate partner violence? For example, perhaps she doesn't use when she only uses when he is in home. Help her identify who to call for help, whether it's family. Does she have family, friends, support folks in organizations, church, agencies who understand what's going on for her and can be there if she needs help? Encourage her to remove substances and paraphernalia from her home, which may reduce the occurrence or amount of her use. And it's also important, especially if coercion focuses on punishing for her use. Help her identify safe people and places if she's going to use. And if children are involved, help planning for their safety. Based on safety planning and harm reduction, how ready is she to make changes in substance use? You can use the readiness ruler. How confident is she that she can make these changes? And then together, you can negotiate a plan which is a part of her safety plan. What does she want to address today? As part of the School of Social Work's SBIRT training grant here at the University of Maryland, Baltimore, we created videos. This video is an example of SBIRT embedded in a community counseling session with a woman who has separated from an abusive husband. While we don't have the ability to show the video here, you can access this on our webpage shown on the slide. School of Social Work, if you actually go to the School of Social Work's homepage and in the search put SBIRT, you'll get to our webpage. I think what also is nice about this video is that it shows how the SBIRT intervention can be used when safety planning regarding intimate partner violence is not currently needed because it has already been addressed. So again, understanding where we come into the interface with this woman who is experiencing both intimate partner violence and substance use is important. What if she doesn't want to make any changes related to substance use? If she doesn't want to or isn't ready to make changes, communicate your concerns for the client's health and safety. Ask permission to revisit this at a later time. Ask her to consider harm reduction strategies. And importantly, express your willingness to be there and to continue the conversation. Some additional considerations. What if she says that the intimate partner violence was in a past relationship or the relationship has ended, but she is still using substances in an at-risk category? One question I have is it really over? We need to explore a bit more to understand if there is any stalking behavior, or if there were children, they have children together, regarding visitation. Are there any instances of abusive behavior? Also, in what ways was she impacted by the abuse? Review the health impacts with her. Does she see any connections between her experience of intimate partner violence and her current substance use? And does she want any further information or referrals? Okay, just a moment, having a little bit of problem advancing the slide. Misty, I seem to be having a problem.
Yes, I've advanced it to referral to treatment.
Okay, so I am not seeing that, but I will continue. What about the referral to treatment of SBIRT? Those women who appear to have dependent use and may meet criteria for a substance use disorder. First, serial approaches are generally contraindicated. I think we all get this. Integrated approaches like TREM, which is trauma recovery empowerment model, and seeking safety exist and show positive outcomes. Know what treatment resources for women in your area exist. There certainly needs to be ongoing coordination between agencies and services where a woman is being referred. One study reminds us that women with substance use disorders and in abusive relationships face specific barriers to reducing drug use and to seeking help after a brief intervention. Why? Because there may be ongoing partner substance use coercion. Also, isolation, which is so often an outcome of intimate partner violence, may make her cut off and create increasing barriers to reaching out for help. Also, the stigma that we've talked about related to both intimate partner violence and substance use. And things like parenting responsibilities, jobs, how does she deal with getting into treatment related to these issues. And of course, what we all very much understand, that any services should be trauma-informed services. Let's move on to documentation. The use of documentation needs to be thoughtful and purposeful because documentation can influence safety. Records can be subpoenaed. So I think this really depends on the setting that you're in, but I think what I mean is that we need to have very thoughtful conversations about what we need to document and why, and be very purposeful in these conversations and the decisions that we make for these reasons. Do document in a way that links symptoms and behaviors to the abuse, and do document efforts that the woman has done to protect and care for children. Guiding principles when considering SBIRT. Regard the safety of victims as a priority. I hope I have underscored this today. I think this is a conversation that as you look at employing this intervention, you really have to think about in your particular setting. Honor victims' autonomy by recognizing the process of deciding whether or not to leave an abusive relationship. It can be complex, long, and gradual. Treat patients with dignity, respect, and compassion, including sensitivity to age, culture, ethnicity, and sexual orientation. Does it make a difference which door she comes in through? That's the next slide. I would say no and yes. No, providers need to meet her and seek to understand her full experience, whichever door she comes in through. This emphasizes universal screening for intimate partner violence and substance use, whether you're working in an EAP program, primary care, a substance use treatment program, the emergency department, counseling services, or reproductive health. Yes, it makes a difference in terms of what information you may already know, what assistance she's looking for, and what do we know about which interventions work best in this setting. Next slide. How do we fail victims of intimate partner violence who use substances? I think one of the main ways that we fail victims is through silos. Silos keep victims from receiving holistic treatment that understands these connections. We need to collaborate across settings and expertise. I hope, if nothing else, from this webinar, you have a deeper understanding of how these two issues are connected and how silos would really not be serving the best interests of keeping women safe and getting them the services that they need. And on the next slide, how we can do better. Screening for IPV and substance use should be routine in all settings, as I've just talked about. Train domestic violence program staff in SBIRT. Hello, am I there?
Yes, you're here.
Okay, sorry. Train domestic violence program staff in SBIRT so that at-risk substance use is not an automatic disqualifier for services. Inclusion of intimate partner violence, substance use, and their co-occurrence in behavioral health professional training and continuing education programs should be a must. Integrated and coordinated systems of care for intimate partner violence and substance use. Interventions, as I spoke of earlier, such as Seeking Safety and the Trauma Recovery Empowerment Model, have shown effectiveness, but the availability and access to these may be a barrier for many women. What we need to better understand, really quite a lot. We need to better understand women who use substances and are experiencing or have experienced intimate partner violence. We need to keep listening to the voices of these women. Are there differences between women whose at-risk or dependent substance use began prior to experiencing intimate partner violence and women whose use began after? We need to understand better the effectiveness of integrated screening. How do we best put multiple screenings together? And I think there is work being done on this. And we need to better understand the effectiveness of integrated interventions for intimate partner violence and substance use across settings and point of intimate partner violence disclosure. What works for who and where? I'd like to end at this time with this quote. Curiosity is especially important in deepening one's care and concern for another person, because even in a close relationship, much that one needs to know and understand about another person in order to care deeply will not be apparent without active seeking, even for the person who is extremely attentive and interested. Intimate partner violence and SBIRT interventions are approaches that embody active seeking on the part of the practitioner to genuinely understand the individual and to communicate our care and concern. For many individuals, this relationship is a key to the process of change. Thank you very much. I'll send it back to Tracy, and we'll try and take any of your questions or comments.
Thank you, Michelle. I really appreciate all of the information and guidance you've been providing us on the webinar today about the intersection of IPV and substance use and ways of approaching it, the tools, thinking about, just sharing with us even some of the languaging around opening a conversation. That's always a real challenge. Just focusing on alcohol screening in and of itself, and you're having to open the conversation about a number of different concerns. So I think that's very helpful to see that the language and the resources and the tools, and there's some interesting questions here. It really reflects a great deal of interest in really understanding this topic better, and how even some of the sort of the very specific details about the things that get addressed or don't get addressed when you're having a brief intervention. And one of them popped out for me, I thought was particularly interesting, and we're going to get to those questions shortly, but I want to remind people, if you are not familiar with the GoToWebinar platform, typically in your upper right-hand corner, there's a questions pane, and at any time you can go ahead and enter your question in there, and we have plenty of time for questions, so go ahead and get those in, and we'll start taking questions that were entered much, much earlier as you were triggering a number of thoughts from folks.
Great.
So what I thought was one comment / question, let me find it, I thought was particularly interesting. And let's see here. There are several coming in at the same time as I'm trying to. So the question was about removing paraphernalia, and that was interesting. I think the comment, and I'll find it, just here it is, okay. Wouldn't it be possible that you would increase the risk of harm for a woman if she removes the paraphernalia from the home? What if the abuser becomes more agitated or violent once he notices it's missing? Any thoughts about that?
Well, a couple of things. Yes. First of all, we're talking about it from the vantage point of the woman's use of substances. So now, and again, I think it goes back to, so that's one thing, just be clear on that. But then I think it goes back to that particular woman's experience. She's going to know her experience best, and she's going to know what is most likely going to create more problems. So we have to listen to her. You can suggest it, you can bring it up as an option, and then you need to listen to her. And if she says, oh no, that wouldn't work because, every night as soon as he comes home from work, he expects us both to light up, and therefore, if all of a sudden that wasn't there, that would create a bigger situation. But if it's more around her looking for ways to try and either reduce her use, or if part of the substance use coercion has been about punishing her for use, if she takes the paraphernalia out of the house, then that may not trigger that for the abusive partner. I hope that answers the question.
Well, thank you, Michelle. And it reminds me, too, of some of the different models of SBIRT, and it's labeled different things in different models, but in the menu of options, we also often call it the menu of options. We train around offering a menu of options and offering it as a possible option for consideration among many, and letting the person kind of reflect and think about what would be best given their own experience. So
exactly. Again, as with SBIRT and when working with survivors of IPV, she's the expert of her experience.
Well, thank you. Thank you. We have a few more questions coming in. So this is an interesting one. Even though it's very sort of basic and straightforward, I think it reflects our change in language over time. For example, this question says, is it better to say IPV, intimate partner violence, versus saying domestic violence? What is that a reflection of, and any thoughts about that?
Yeah, I think this is, and some people use family violence, which really includes many other things as well. I think this is the progression of the field and the movement. But again, I think I take my cues from that particular woman. What words does she use to describe her experience? And if we use intimate partner violence, we can be very, we can explain why we're using that terminology as opposed to domestic violence. Why are many people not using domestic violence anymore? Because, that connotes a violence that happens in the home, where many relationships, whether it's intimate relationships, be they dating relationships, or other types of, like the relationships described in the CDC definition, don't necessarily happen in a shared home. So I think it's a process of, again, having a conversation. I don't think there's a right or wrong per se, just being clear on why, where that term is coming from.
Well, thank you. We have another question here, and as your poll results indicated, folks, some have had SBIRT training, some have not, kind of a mix of folks. Mm-hmm. You mentioned the readiness ruler. Can you describe what the readiness ruler is, and perhaps how you've used it in this particular context?
Sure. So the readiness ruler is one of those tools used in both motivational interviewing and in the brief intervention of SBIRT, and it's using a simple scale of 1 to 10 and asking, on a scale of 1 to 10, how ready are you today to make any changes towards whether it's reducing your substance use. And when the client or the individual responds with a number, the next step is to say, so if she responds with a number, I think I'm probably 5. Then the next response is, well, tell me why you're a 5 and not a 2 or a 3. And this is very intentional in the SBIRT model, and I really encourage you to. There's so many wonderful, both online and in-person SBIRT trainings to take one, because this really allows the person to build sort of a sense of efficacy in that they have done some work, and helps them sort of elucidate and really name why it is that they are further along that readiness scale than maybe they even had recognized. Maybe it's partly due to the conversation that you've had together in that session. Maybe it's based on things that she's been thinking about or other people that she's come in contact with, but it allows her to really hold on to her readiness to change. And then often that's followed with the same sort of tool or intervention in terms of, tell me then on a scale of 1 to 10 how confident you are that you can make that change. And, I think especially with this population that, will give you and her some very important information. She may say, well, I believe I'm a 5, and you again might ask, why are you say you're a 5 and not a 2 or a 3? And she say, well, I'm fairly confident I can do this, but not while I'm still living with him. I feel like I need to, that needs to be first on my priority list, is I need to work towards getting out of this relationship. That's just one example of how this might play out.
Thank you, Michelle. I think that's a great example. And, to follow up on something you mentioned around training, we, as a part of the National SBIRT ATTC, we have a number of freely available online training programs, both that are in motivational interviewing. There are courses in motivational interviewing. There are foundation courses in SBIRT that are all available. And so we can, I'm going to ask Misty to try to find a link directly to put into the chat box so that you can link to that. But also, you can even just Google National SBIRT ATTC, and there are online trainings readily available to you. So please take advantage of those resources. Question for you, Michelle. It's come up about questions about screening. Do you use the same screening questions when it's a male client or patient? In terms of relationship safety, it appears specifically. So I think there are kind of two questions here. Is, do you use the same screening questions for males and females, particularly the safety questions?
Well, in terms of the screening questions, are you talking about, so you were talking about the screening questions for IPV as opposed to the screening questions for substance use?
I think if I'm interpreting the question right, I think it's about IPV specifically.
Right. You know, this is sort of maybe perhaps a bit more, there's more discussion in the field around some of this. I mean, I think if you are in a setting where you see both men and women, you should select one of the validated screening tools for IPV that is appropriate for men and women. And I do believe that we should screen all men and women. Now, the Preventive Services Task Force, in their recommendation, they talked about, because of the prevalence of women as the majority survivors of intimate partner violence, their recommendation was around universal screening for women of reproductive age. Like, that was the major group and population that they were making a recommendation on. I do believe that we should ask, again, it sort of depends on your setting, what's the most appropriate screening mechanism, but if you are seeing men and women, I feel like we should be asking all folks about the occurrence of intimate partner violence in their relationship.
Thank you. Thank you. I think that answers the question. And I believe this also has come up in some of our other webinars on this topic, on demand. So I would encourage folks to take a look at some of our on-demand offerings and also join our future webinar coming up where the presenter has talked about screening males and females and the application of programs and approaches to males and females. So I would encourage you to join that and again, ask the same question to that presenter as well. Thank you, Michelle, for sharing your perspective. We have another question that's come in. And we have a mix of folks between providers and substance use and healthcare and mental health and IPV and academics who are really thinking about how are we educating our students to be prepared to enter the workforce. And so this question is, what are your recommendations when training SBIRT to students who have very little IPV knowledge or experience? I'm concerned about opening a door to this information without being able to go into depth, which may do more harm than good. What are your thoughts about that?
That's a great question, and I think one that we have struggled with here. So when we have, with our SBIRT training grant, we basically have infused SBIRT training in two ways into our curriculum. One is in a foundation course where the students, which every student has to take. So then this consists of a 3-hour online module that they do prior to a 3-hour in-class presentation on SBIRT, which has made a lot of practice in our videos, the in-class portion. So in that one, we just talk about at the end, like, other considerations, future, other ways that brief interventions are being used and what's the sort of state of the research and that sort on these areas. So we we've specifically mentioned things like IPV and gambling, screening, brief intervention. But we, just that's there, that it looks different because of somewhat different because of the issue, and if people are interested, that's an area that you could get further training or explore. The other way that we infused SBIRT is that we created a 1-credit course, which is a 15-hour course, which also used a standardized patient. And in that one, we had more time, and so we were able to do a more, spend more time talking about SBIRT and intimate partner violence, and looking first at some of what I did today, like what is screening and brief intervention for intimate partner violence, and how do these two issues overlap. And again, I think it's always sort of encouraging. I still feel like making people aware, and it's certainly the information on prevalence and co-occurrence and bidirectionality of these issues is important for graduate social work students to know, and to encourage them to get further training. We in terms of, I'm sure IPV comes up in several different courses in some way. Same with substance use in the curriculum, but there is only one course, and it's an elective, in intimate partner violence. And I don't think that's not, I mean, I think that's fairly usual for a lot of graduate schools of social work. It's a good question, and not an easy answer there.
Exactly. Well, thank you for responding to that. We have a few more questions that have come in. You talked about the serial approach in terms of that versus the other, I guess, more integrated approaches. Can you define what you mean by a serial approach?
Well, I'm going to speak to it from my own experience, having worked in the domestic violence field or the intimate partner violence field for many years. At that time, if a woman came to us who had, first of all, I think we had, a naive, not a very full understanding as we do today of the different categories of substance use. We didn't look at it, and we looked at it very much the way, unfortunately, some people still do, that you were either not a substance user or you were, a dependent, you had a substance use disorder. So when a woman came to us who was using substances, I think oftentimes the first step was get her into substance use treatment, because she's not going to be able to avail herself of our services. I mean, I'm saying, if she doesn't deal with that first, and that's the biggest part, perhaps, of safety for her. Same with abuser intervention programs, where if a man was charged with a domestic violence offense and he had been using at the time of arrest, and he was court ordered to both abuser intervention and substance abuse treatment. Well, it was like, do the substance abuse treatment first, and then he can come to the abuser intervention program. And so I think we failed on a couple of fronts. One is, not addressing both of these, finding interventions that are integrated and that look at both of these issues at the same time, because they are so interwoven. And then secondly, that we were leaving out this whole category of folks who are at-risk users, and not addressing that at all. They may not have, of treatment referral, it may not have been, an appropriate intervention for what was going on for them. And something like SBIRT may make much more sense in that situation. So, so I think we need to continue to move in the direction, and I think abuser intervention programs have done this better than IPV, for programs for victims, in terms of integrating substance use treatment with the abuser intervention program.
Thank you. Thank you. Okay, let's see. I think we can take another question before we wrap up. see here. How can we help clients understand that play fighting may be the beginnings of IPV? And I don't know if that's within the sort of the scope of more of the brief intervention. Does that become part of the brief intervention piece of it? Can you
I'm sorry, I didn't. Can you say again what I didn't hear the very first part of the question. I'm sorry.
Yeah, so how can we help clients understand, and it's in quotes, play fighting may be the beginnings of IPV?
Yeah, that's a really good question. I think some of what might be helpful is looking at some of the work that's being done with adolescent relationship abuse, and some of the prevention work that's being done, and and highly regarded in terms of talking about the differences between healthy relationships and unhealthy relationships with young people. And depending on, I'm not sure if you were talking about younger folks or anyone or any particular age group, but I think some of this in terms of really trying to ask the questions to help the person understand what are the feelings associated with being a respondent to that behavior, or what in both directions, I guess, depending on who the person is that you're working with. And I'm always a big fan of sort of like continuums, and sort of talking about how things exist, how behaviors and their impact exist on a continuum, and being mindful of how things may progress through up a continuum. But that's a really great question. I don't have necessarily a great answer for, but I do think looking at some of the prevention programs around adolescent relationship abuse is a good place to start.
Yeah, thank you. Thank you for that. And I think what we'll do is we will begin to wrap up. And I wanted just to, maybe I'll follow up with you afterward. You can think about this. But this is certainly a topic that it has great interest and something we encounter a lot. And one of the questions that I get is, where can I find good, credible and information on addressing IPV and using an SBIRT framework to address substance use in the same context. And we talk about BNI and frames and all of these SBIRT models in the context of substance use. And maybe there's been an adaptation of these models in having conversations with clients and patients about these issues. And one of the questions I get is, what goes into the brief intervention? What does the dialogue sound like? Really helping the practitioner understand what goes into that conversation, and you've provided some of that today. So I may follow up with you to get your thoughts on what are the resources out there that would be really good to look at. Are there checklists and algorithms like we use in SBIRT that help us in having these conversations? So I'm going to plant the seed for you, and I'll follow up with you. You can give that some thought, but it's certainly a common question I get. So thank you, Michelle, so much for this terrific webinar, and I really appreciate taking time to answer the questions and for the thoughtful questions that folks have been submitting, and for the attendees for taking time out of your day to give us the opportunity to share with you this education. And so in our last few moments, I just want to remind folks that the PowerPoint slides are available on the hospitalsbirt.webs.com website on the page dedicated to this webinar. In addition, this is where you'll be able to request your certificate of completion. And the certificate of completion, there's a brief online form, and you'll go through that process in order to receive that and also to receive your CEs, the 1.5 NADAC credits that we offer to you at no cost. If you are planning to watch this on demand or share this with a colleague and they're going to watch it on demand, all the on-demand participants can also receive a certificate of completion. After going through the entire webinar, they'll be able to complete the continuing, the online form to get that certificate. The on-demand recording of the webinar will also be placed on the web page for the webinar, available 24/7. And also in our last minute, we have a very, very short evaluation survey. Misty has already put the link up in your chat box. Please go ahead and complete that. You will also be getting a follow-up email, but to complete it, but go ahead and complete it now if you can. Completion of these surveys is really very critical to helping us to be able to maintain this webinar series and offer you this valuable educational content, and having terrific presenters like Michelle be able to share their knowledge and expertise with you. So please complete that survey for us and look for the follow-up email from us as well, giving you links and information to where all of these things are housed in case you didn't catch any of those things that I just shared with you. And also, let me just close by saying that if you have technical assistance needs as part of the National SBIRT ATTC, we welcome your questions. You can send those by email. You can give us a call. If you'd like a telephonic technical assistance session with us, we're here and available to help you. And so last but not least, let me just thank you again for attending, and thank you to our partners, the National SBIRT ATTC, to NORC, to the Brief Intervention Group, and of course to Misty and Michelle for this terrific webinar today. And please look for more information from us and more materials on our SBIRTeducation.com website. Thank you, Michelle, and thank you for everyone for attending. I hope you have a great day.